Bronchiectasis, a lady complaining that from childhood she is having copious sputum continuously. Before marriage, after the birth of the first child, second child, he went to America, she said goodbye. But the problem of the productive cough with copious sputum is continuing. Don't forget to examine her, the fingers. Clubbing is evident. Auscultate, valve crepitations will be heard because of her bronchiectasis, which is a very classical feature which you should not basically forget. What's the most common organism causing pneumonia in the diabetic individual, doctor? Alcoholics, diabetics, COPD. Don't forget Klebsiella pneumonia, which causes necrotizing lobar pneumonia. Similarly, in the diabetic ketoacidosis, Streptococcus pneumoniae and Staph aureus are quite common. And chronic obstructive pulmonary disease, two organisms, Moraxella catarrhalis and Haemophilus influenza should not be forgotten. Solid organ transplanted individuals, early transplant, late post-transplant. Early occur more than 3 months after the transplant is the Streptococcus pneumonia is what need to be remembered. In sickle cell disease, capsulated organisms, Strep pneumoniae and H influenza. HIV infection with a CD4 count greater than 200 ml, then what are we going to find? Cryptococcus, Mycobacterium, Rhodococcus can lead to development of pneumonia. CD4 count lesser than 200, then Pneumocystis pneumonia and MAI, that is a Mycobacterium avium intercellular infections are going to be quite common. So this is an example of a bulging fissure sign that you see in the case of the Klebsiella radiologically, which is going to be the favorite question of the examiner. Cardiac tamponade, what are all the various things that are going to see? This question also a little controversial. Thing is, Kusumal sign is seen in cardiac tamponade but not characteristic of cardiac tamponade. It's more characteristic of constrictive pericarditis. If you do the 2D curve, classically, because of this restriction imposed by the surrounding edematous fluid, the ventricle and atrium cannot be filled with the blood at the time of diastole. Hence, at the diastole where you are expecting the ventricle and atrium to be bulging, they will be in fact be collapsing. So that's the reason on 2D echo, finding of the free wall of the right atrium to collapse is a classical feature in the case of the cardiac tamponade. What is Kusumal sign, doctor, classically? Kusumal sign is fundamentally at the time of inspiration, you expect that the JVP need to basically drain all its blood and need to collapse. But the JVP remains distended even at the time of the inspiration is called as the Kusumal sign, which is seen in the case of the constrictive pericarditis. Can you tell me what is the common cause for the constrictive pericarditis in this part of the world, doctor? Tuberculosis is the most common cause. So history of tuberculosis, receiving anti-tuberculous therapy, a village farmer has come to you, prominent JVP is appearing, which is not falling at the time when he is taking inspiration, very prominent it is there. Initially you thought, is there any superior vena cava syndrome? Nothing is there, but he is also having dyspnea. Then you correlate these cardiac clinical features with that clinical sign of elevated JVP even in inspiration called as Kusumal sign is equal to constrictive pericarditis is something that you should not basically forget. But sometimes it can be found in the cardiac tamponade also. Now Pulsus Paradoxus, what do you mean by that, doctor? Normally inspiration leads to decrease of the systemic BP. But if there is any exaggeration of this phenomena, then it is called as the Pulsus Paradoxus. Pulsus Paradoxus does not mean normally inspiration there is a decrease in paradoxus, in expiration it will decrease. That is not Pulsus Paradoxus. Be very sure about it, doctor. Paradox is while listening to the heart sounds, you will be feeling the pulse. So at the same time you are auscultating the heart sound. You are able to hear the heart sound but the pulse is not felt at the time of inspiration. What is the cause? Because at the time of inspiration, the systemic blood pressure has so much fallen down that the pulse is not palpable while the heart sound is still hearing. What is paradox is what you studied in high school versus what you studied in medical college. High school sir said heart is beating means pulse is palpable, but here heart is beating but pulse is not palpable. So that is the paradox, because the inspiratory fall of the blood pressure at the time of inspiration is what need to be remembered. And it is seen in constrictive pericarditis, restrictive cardiomyopathy and pulmonary embolism is what need to be basically remembered. What is electrical alternance, doctor? If you take the ECG of a patient who has got a huge effusion, in him classically there is alternation of the QRS complexes, their what you call their voltages will be alternating is what you call as electrical alternance is what need to be remembered. So let's go to the next question. In SVT, do you find heart rate of 200 to 300, doctor? Generally it is between 140 to 220 is what need to be basically remembered. So SVT versus VT. I mean SVT with aberrant conduction to the ventricle versus VT. One of the favorite questions of the examiner. Similarly SVT management protocol and VT management protocol. If the hemodynamics are alright, how you will manage? Anyway, when the hemodynamics are not alright, then doing a DC shock is the only thing that you can do. If the hemodynamics are alright, then do you want to give amiodarone? Do you want to give lignocaine? How much you want to give? These are all the favorite questions of the examiner. You can't afford to do a mistake, doctor. Let's go to the next question. Acute pericarditis, what is not a feature? Pulsus alternans is more often a feature of which condition, doctor? Pulsus paradoxus is different from pulsus alternans. One beat is strong, one beat is weak. So when do you find that? If there is any left ventricular dysfunction, typically the patient will be developing pulsus alternans is what need to be remembered. A patient who has got a aortic stenosis, which is very severe, then what type of pulse do you come across, doctor? It's called pulsus et tardus. That is, it takes a long time to have its peak. So it appears when you feel the pulse of a severe aortic stenosis patient, it appears as such somewhere from the bottom of the earth it is coming down. Slowly is the feeling you will get. Whereas you catch the patient who has got thyrotoxicosis or a PDA or a pregnant female, then the bounding pulse will be found. Okay? And where do you come across typically the pulse, which is if you lift, it will be collapsing pulse, water hammer pulse, aortic regurgitation. Last type of pulse you should not forget is pulsus alternans, which is found in the LV dysfunction. So 4 different types of pulses. Pulsus alternans, LV dysfunction, pulsus paradoxus, pericardial effusion, and in the case of constrictive pericarditis. And the third type of pulse is pulsus et tardus, is found in aortic stenosis, and these are very important part. What is the most common site for the pheochromocytoma other than adrenal, doctor? Organ of Junker candle or Junker land? Okay. What is the most common cause of the endogenous Cushing syndrome? Pituitary microadenoma. Chromophobe or chromophilic? Because the examiner can ask you that also. You finally understood it is pituitary but forgot is it chromophobe or chromophilic. Finally you will be fighting and juggling in the tomorrow's exam. So that is very, very important part. So endogenous Cushing is commonly because of the pituitary adenoma is what need to be remembered. Exocrine pancreatic insufficiency does not lead to endocrine problem, that is the diabetes is what need to be remembered. What do you mean by ARDS, doctor? Non-cardiogenic pulmonary edema. That is the reason you don't find abnormality in the heart. If you found in a failing heart with pulmonary edema, it is no more called ARDS is the golden rule. How do you know heart is working well or not? Check the radiograph, heart is dilated or not will be known one way. Other way is check the pulmonary capillary wedge pressure. If it is normal but pulmonary edema is there means it is a non-cardiogenic pulmonary edema with a normal PCWP is what I want to underscore. PCWP indicates which pressure, doctor? Left atrial pressure. Excellent. You are all ready to take 5 years DM cardiology course, doctor. So how many want to be physicians among you? Can raise the hand boldly. That's good. That's good. I want to see among the what you call our women doctors also, because there is a need for better neurologists, better cardiologists. And some people, at least in our community, there is a lot of importance of the female physicians, which is the number is relatively lesser. So beta blocker should not be used with what? Something else which is also causing a negative inotropic state. So what is that, doctor? You can't use it along with the diltiazem is the golden rule. Tell me, what are the 2 things that can make the patient to go into a total cardiac failure, doctor? If there is any calcium channel blocker, which is negatively inotropic, plus a beta blocker, which is also bringing down the rate of the heart, this combination is there, then it can land the patient in heart failure. Sometimes we will induce the failure of the heart. Why can't it be? Verapamil and diltiazem, what is the difference, my sweetheart? Verapamil is more, verapamil also is a similar group, but relatively between verapamil and diltiazem is much more strong against the heart. I mean the muscle of the heart. See, in SVTs what do you use more commonly? Verapamil. Of course, this diltiazem also has got a good effect on the conduction tissue, but generally diltiazem plus beta blocker is known quite clinically, leading to precipitating to worsening of the heart failure status. Complication of the diabetes which is caused by the non-enzymatic glycosylated products. What are they called as? Amadary products. Amadary products. So they are typically leading to arterial atheroma. What is the reason, doctor? This non-enzymatic glycosylated end products will go, sit on the vessel wall, invite the LDL, and the LDL will deposit that cholesterol, I mean that fat tissue in there, and that lead to development of the atherosclerotic plaque. So who is inviting the LDL? In a patient who has got uncontrolled diabetes. Uncontrolled diabetes lead to hyperglycemia. Hyperglycemia leads to non-enzymatic glycosylated products. Non-enzymatic glycosylated products will go and sit on the endothelium, invite the LDL, make it to deposit the fat tissue, and that leads to atherosclerotic plaque. Hence the arterial atheroma is a common complication of the diabetes associated with the non-enzymatic glycosylated end products is what need to be remembered. In iron deficiency what happens, doctor? Decreased serum iron, decreased ferritin, decreased saturation, but increased TIBC is what need to be remembered. How to differentiate iron deficiency anemia from anemia of chronic disease? In both the cases serum iron is low, but in the case of anemia of chronic disease ferritin is high, because in chronic disease or chronic inflammation ferritin acts like a acute phase reactant, hence it becomes elevated. So that differentiates iron deficiency anemia from the anemia of the chronic disease. I think we had been discussing the same fact in multiple exams, but finally these are the things that are asked, doctor.